There are a couple of important trends that are developing with NAFLD. First of all, with the aging of the NAFLD population, we are seeing increasing number of people presenting with advanced fibrosis. And the burden of patients with advanced fibrosis and cirrhosis from NAFLD is steadily increasing. In 2016, we had done a modeling to show that the prevalence will double between 2015 and 2030, and the data appear to suggest that we are on track for that doubling. So this highlights the urgent need to tackle the public health problem of fatty liver disease. So you're absolutely correct. The incidence of HCC is increasing and is very closely linked to the presence of underlying NAFLD. So let me go step by step. First thing, if there is a strong family history of HCC, then that's the population that you should pay attention to. Number two, people who have advanced fibrosis are more likely to develop HCC. So the risk of HCC increases exponentially as you go from stage 0 to 2 to stage 3 and then stage 4. And a good simple way to identify that population is to use a test called FIB4, which is not perfect, but correlates reasonably well with the presence of underlying fibrosis. FIB4 is widely available and requires you to know the age of the patient and get AST, ALT, and platelet count. And if you put it in your FIB4 calculator on Google, it will give you a number. And so if that number is above 2.6, then it identifies a high risk for, it enriches the likelihood of developing HCC in the future. If NASH and NAFLD is an etiology for development of HCC, it would logically follow that if you treat these conditions effectively, you will reduce the incidence of HCC. Is there evidence to that fact? We don't have the kind of long-term studies because it still takes many years for HCC to develop. And particularly most of the clinical trials are in patients with stage 2 and stage 3 disease, where, especially for stage 2, the incidence of HCC is still in absolute numbers still fairly low. And so we need longer studies to have the evidence base to be able to say that, but it's a logical assumption that if you treat NASH, the incidence of NASH-related HCC will decrease. The first issue is in people with early stage fibrosis, because the incidence of HCC in people who have early stage disease is very low. Now for the individual who gets HCC, it's a big deal because HCC is HCC. And so we need tools to enrich that population so we know within that early fibrosis stage population who is particularly at risk and develop more intense surveillance strategies and prevention strategies for that population. You cannot do trials of preventive strategies when your incidence of the disease back in the background is very low. For people with more advanced disease, we need these long-term trials with effective NASH therapies to show whether we can actually reduce the incidence of HCC. Now, once HCC develops, we also need better understanding of whether the HCC in the setting of NASH behaves the same as HCC developing in the setting of viral hepatitis. So there's emerging data that checkpoint inhibitors, for example, may not help all patients with NASH and may actually cause worsening of HCC in some patients. So we need much more clarity on that. And in Asia, particularly, where a lot of patients have comorbid viral hepatitis and NASH together, what is the biology of the disease? We need a lot more data. This is an urgent need to further improve precision approaches for the treatment of HCC in those populations.